Okay, so firstly, thank you, Joe, for inviting me to speak today. For those of you who don't know who I am, I'm Laura Hopestone, as Joe's introduced, and I'm the health psychologist at Liverpool Ocular Oncology Centre. And I'm also a research fellow in oncology at the University of Liverpool. I've been at the Liverpool Ocular Oncology Centre since 2010. The post of health psychologist was established back in 2004. And one of the reasons being is that because patients, when they come to Liverpool, they get treated very quickly. A lot of the attention is around their clinical need. It's about getting them treated. And Prof. D'Amato at the time felt that he didn't want to neglect the psychological problems that people might encounter with a diagnosis of ocular melanoma. So he established this post. And so it's around the psychological support and intervention for patients, but also to carry out service evaluations, audit and research, and hence the collaboration with psychology at the University of Liverpool. So today I'm going to talk, there's two talks today, there's this one now and there's one after lunch, and again thank you, Joe, for accommodating my needs as I need to get back up to Liverpool this afternoon. The first part of the talk is around the psychological impact of a diagnosis, and the second part will be living with ocular melanoma and coping with liver surveillance. So I'm going to talk about some of the psychological responses that people can experience. I'm going to look at the impact on patients themselves, but also on the others, people around them. I'm also going to touch on decision-making, because there often is a decision to make about sometimes around treatment, but sometimes around whether to have a prognostic biopsy. I'm going to talk about ways of coping, and I'm going to talk about the whole process as an adjustment process. And I also want to bring in at the end of this afternoon some work that we're doing at Liverpool in terms of our research and how that can influence the care that we provide for our patients. So when I was thinking about doing this talk, I had this image in my mind of a pebble hitting a pond. And then when I looked at it again, because I was thinking about the far-reaching effects of this, not just on the person themselves, but the people around them. But actually, it's not a pebble in a pond, is it? It's a depth charge. And it comes from nowhere. And there you are, just going along your life. There might be some rocks along the way, there might be other boats in the area, it might be a bit choppy, but all of a sudden, this happens. And this gives rise to a lot of different responses. People talk very much about the shock of it all. It's like a bolt out of the blue. And often people talk about it feeling very surreal. It's like I'm watching a film of myself, and there's this kind of, it doesn't seem real at all. And people talk about that quite often, especially in the early weeks following diagnosis. And there's this disbelief as well. People say, I didn't even know you could get eye cancer. And people sort of look at you a bit oddly. So what? So you may have gone just for a routine eye test, and around 30% of patients won't actually have any symptoms. So you go from walking into Specsavers or Vision Express or wherever, and suddenly somebody says something. So you can go from that to a rare cancer diagnosis. And even if you do have symptoms, there may not have been, there might have been a few floaters. Maybe you thought, something's not quite right here. So it might not necessarily be dramatic. Obviously, for some people there is, and there may be sudden vision loss. And there's few terms of reference. This is something we don't really know, we don't really understand. A lot of people say to me, it's like, but there's nothing wrong with me. I feel completely well. And that just doesn't sit with our idea of actually having something seriously wrong with us. Because when we notice something we have a symptom, we have a lump, a bump, a bleed, we think, oh yes, there's something, this is not quite right. And we go through this kind of process. We go to see the GP, we might go for a scan, and someone might do a test, and then you might be referred. And that all takes quite a lot of time. But with this, you can go from having, as I say, an eye test and being up in Liverpool, for instance, within a week to 10 days. And along with this, there's this sense of this control being taken away from you. All of a sudden, you have to relinquish control. You have to put yourself into the hands of other people, professionals, people telling you what to do, taking you places, dilating your pupils, sticking you in on the, to have a look at your eye, taking photos. There's an awful lot going on, isn't there? So since my diagnosis, everything has changed. Everything feels upside down. I'm no longer in control over my life, and I just don't know what to expect anymore. I want to go back to the person I used to be, and I can't. And alongside this relinquishing of control, which is not comfortable, we don't like it, there are these very, very powerful, profound emotional responses. Tearful, feeling very anxious. Some people become very withdrawn. Some people are just very, very sad and low. But for a lot of people, they feel quite numb. And that ties in with that sort of surreal quality. It doesn't quite feel like it's happening to them. You feel very vulnerable. You're under threat. And there's those feelings of anticipatory losses. What will happen in the future? How will I live my life? How long have I got? And there's often anger as well. There's anger about, especially if people things haven't quite gone as they probably should have done. Maybe they were misdiagnosed, maybe something had been missed. But people get very angry. And that's obviously born out of fear, but also some people are looking for someone to blame. What can happen is people start blaming themselves. But as far as we know, there isn't really a cause for this, is there? Unless someone can correct me, but it's, we don't really know what causes this. So you can't really say, well, it's because I did this or because I did that. And all these emotions, these are normal human responses, aren't they? To when something very abnormal and very dramatic happens. And you can't necessarily bypass the emotion. You might be able to put it on hold. You might be able to delay it as you go around your business and getting things sorted. But it will probably hit you at some stage. And it might not be immediately. But that's okay, actually. It's okay not to be okay, because these are normal human responses to a very abnormal situation. So the impact on others. So you found out this information yourself. When, what, and how do I tell other people? Because we worry about those closest to us, don't we? How will other people cope? How will they react? It may be sort of elderly family members. Do you want to upset them? I don't want to worry my family. Again, that's quite natural. But also maybe it's about telling children. And people often come to me and say, well, I don't know when and how, and I don't think I will tell them. There isn't a right and wrong answer. But if you do decide to tell children, it's better that you tell them rather than they hear it from someone else. And children of all ages are very much more savvy than they were, and they will look things up. So it's better that you can control what you tell people, and that's the advantage in a way of you telling people, and not can get a bit third hand. A diagnosis of cancer, regardless of where it is, can have an enormous strain on people's relationships, close relationships, understandably. You're both under a lot of pressure. The family is under a lot of pressure. And it won't necessarily create difficulties, but it might expose difficulties that are already there. And then there's friends. Do you want to tell them? When do you want to tell them? Because once you've actually started saying it out loud, once you've said, I've actually got this ocular melanoma, it's out there. You've said it. And that's part of the process of actually slowly adjusting to it. Employers and colleagues and employees, what do you tell work? What do I tell work? What am I going to say to them? Because there's nothing wrong with me and I don't look ill. So that's sometimes a problem. And it depends on what context you're working in. I mentioned about decision making. And people sometimes do have to make very difficult decisions at a time when they're feeling very emotional. We know ourselves that if we're feeling emotional, can't concentrate very well, someone's asking you to make a decision about it, something, you might not necessarily be able to do that. There may be a choice between having the eye enucleated or having, for instance, proton beam radiotherapy. You might have to make that decision. The prognostic biopsy, should I have it? Shouldn't I have it? What happens if I do have it? How will I feel in 6 months' time if I don't have it? I do have it. And then further on, maybe if you are at low risk, should I be having liver scans? These are all decisions. And who should I tell? Just going back to what I've just said. And individuals make decisions in lots of different ways. And some people have very much sort of gut feeling. Right, I just, for instance, if it's a choice between a nucleation and proton beam, I just want to get rid. That's what I want. That's my sense of it. And people use sort of what's called heuristics, like mental shortcuts. So we often make decisions based on what we've heard, how we're feeling emotionally. I want the eye out because I don't want to worry. So what you're doing there is actually managing your emotional side of it by having a surgical procedure when perhaps there was another option. I'm not saying there always is, obviously. We also base things on what we hear from other people, what we hear third hand from other people. But it might be our own past experience of how we make decisions. It might be you're one of these people that weighs things up very carefully, sits down, goes through the whole list of pros and cons. And there's those who might be doing all the information seeking, or the going out there, finding out things. And then asking others. And that could be other healthcare professionals, it could be friends, it could be people you know who might know something about it. And this is at a time when you've just had that diagnosis and you're being told an awful lot of stuff. There was so much to take in. I felt bombarded with information and I couldn't think straight. I had to make decisions about my life, my future, everything. So people cope in lots of different ways, and there isn't a right or wrong. But when you do start to respond, when you still start having those emotional responses, that's actually the beginning of the coping process. And responses can be mostly in line with your usual coping. If you're a person who does like to speak to other people and access support that way, that might be your way of coping. It might be that you are a worrier, naturally, and that's what you will do. And they will vary and fluctuate, these emotions. And as I say, maybe you're a worrier, but maybe you're someone who's a slightly pessimistic person. And some of us are. We tend to look on the more bleaker side of things. Or maybe an optimist, and that might be another way of looking at it as well and reframing things. Some people do take positive attitudes to adversity, and they see things as a challenge rather than a threat. Some people try and suppress negative thoughts, pushing them away, distracting themselves, making themselves busy, doing whatever it is just to put some distance between what they're going through and themselves. And as I say, some people might just put their trust in healthcare professionals. We hand it over to the experts, because actually it's easier. Here, you make the decision for me. Some people take comfort in the support of others, and other people don't. Some people want to withdraw, and that's quite natural, whatever works. The problem is when you start to withdraw, you start to put distance between yourself and the people who care about you. Distraction, I mentioned earlier, about keeping busy. That's what I think lots of people would do that, wouldn't they? Well, as long as I keep busy and I keep doing things, I'm fine. Some people may use their sort of faith and their spiritual beliefs to help them along. But some people often find they can't access those at a time when they're feeling so vulnerable. Positive thinking. And the people will often say, well, if you think positive, it'll be fine. And that's fine if you're feeling like that. The problem can happen is that if everyone else is telling you that and you don't feel it, it can actually make you censor how you're feeling and stop you expressing how you're feeling. But if it works for you and that's the sort of person you are, then that's fine. But just be aware it doesn't work for everybody. Benefit seeking. So that's that. They found it early. I'm having the best treatment. I'm going to the best place. I'm being taken care of. Another way people cope is comparison to others. It's got a sort of downward social comparison. So there's people worse off than me, basically. And that can work, actually, yeah, I'm actually okay because that person's a lot worse off. Some of the problems that can arise from that is that people start to sort of be quite sort of hard on themselves and say that they shouldn't be feeling like this because there's people worse off. So I don't know why I'm feeling like this. There are so many people worse off than me. So that can work on different levels. We talked about support seeking, so specialist organisations such as Ocular, there may be peers, specialist nurses. That's what some people want to do. And I mentioned earlier about wresting control, about relinquishing control, and we want to wrest control back, we want to claw back control when all this is happening. And a lot of that is about regaining our sense of who we are and ourselves. And a lot of that is tied up with return to work. And many, many patients say to me, I just want to get back to work, I just want to get back to normal, to get back in control of my life. And that might not be immediately possible. So it's perhaps thinking about the ways you can control some aspects of your life, whatever they are. So now there are more ways of coping. There's lots of them. Emotional venting and disclosure. You might just want to go and sit in a car and scream. You might howl and blub. You might talk about how you're feeling to people. Information seeking, as I mentioned before, and Googling, and we know the dangers of that, especially when you've got a rare cancer. The information, some of it is just plain wrong. And often we do look for good stories, that's what we want to hear, and we might not find them initially. Catastrophizing, the worst case scenario. People will go there. Some people are more inclined to do that than others. And again, it's very individual. Worrying and ruminating. So when we talk about worrying, we talk about sort of worrying about the future and the what ifs. What will happen? Why will this happen? When's this going to happen? And rumination is kind of perseverative thinking. It's going over things in the past. Well, if I'd done this, and if I'd gone earlier, and if I'd gone to Specsavers, and if I'd done this. And we can go over the past, and it can be very painful. It doesn't really get you anywhere. And I also want to mention this, talked about sort of, sometimes we want some distance between ourselves and what's going on. So we have this kind of protective defense mechanism, and in psychology parlance, it's called disavowal. You know it's happening. You're not in denial. People say, oh, he's in denial. He's not in denial. He knows what's happening. He just doesn't want to talk about it. He doesn't want to feel it because he wants some distance, and that is a very natural way of dealing with a trauma. And if we look at cancer diagnosis as a trauma, then that's what people will naturally do as a defense mechanism. Not everybody, but that's what some people do. And there's a quote here from somebody. I guess I'm not letting myself think about it too deeply. Shove it to the back of the mind. You know it's happening, you know it's real, but you don't think about it too deeply because you couldn't cope if you did. It's actually coping because he's doing that. So we have our ways of coping, but sometimes they can be a bit elusive and we can't do the things that we normally do. And that often happens quite early on if perhaps you're having surgery and you can't do the things that make you feel better, like exercise and going to the gym, and perhaps you can't do those things. Or maybe you really enjoy sewing or reading, and you can't do that initially if you've got visual impairment. So you have to try and find new ways of coping. And that's often not easy. Okay. So not only are you coping with the emotional side of things, the psychological side, these things will also impact on your psychological well-being. You're having to deal with visual impairment and loss, and it might be sudden after having a nucleation, or it might be taking months, such as for proton beam. And that's difficult. You may be experiencing double vision, and we know people that, as I mentioned earlier, that who have plaques can get double vision, and whilst we hope that it will get better over time, for some people it does stay, and it's really tricky because you can't get back to doing the things you want to do. You can't get back to doing driving is a real problem for people, because that's a lot of, as I say, getting back to normal, doing the things we normally do. There may be other ocular symptoms, dry eye, watering, discharge. There's also something called phantom eye syndrome for people who've been enucleated. So this is, I suppose it's akin to phantom limb syndrome when people lose a limb, then they can have phantom symptoms. People with phantom eye syndrome can, and around 60 to 70%-ish of patients having an enucleation will experience something. They might be just little visual sensations, but they might actually be more sort of profound scenes and images. And there's also something called visual synesthesia, when people hear a sound, a very loud sound, and it sparks off a visual sensation. So you've got that going on as well. And a lot of people, nearly everybody says it, they're so tired and they cannot understand why they're so tired. Oh, well, you know, there's nothing, I've only been in hospital a couple of days, and, you know, and it's not age dependent, or it's exhausting. I mean, the people I see up in Liverpool, they've done, there's been a long distance, they've made journeys, they've been told stuff, they've had to think about stuff, they've had to make decisions, they've had to tell people. Then we, if they're having a plaque, get 2 anaesthetics within a couple of days. And then we pop them back home. And tiredness can affect our concentration. And also, in terms of one's vision, you take all the information you need, usually, through 2 eyes and process it. But if you've got one eye that's not working or is not there, that other eye is going to do a lot of work, and all that can make you tired. And there's also things like appearance concerns, and that might be, you know, all sorts of different things. Often people say, I just don't want people looking at me, I don't want people staring. So all this is going on, as well as all the emotional response that you've got. So ways of coping with self and others' responses. So we're quite hard on ourselves, and people so often say, well, I'm usually the strong one, I'm usually the one that sorts everything out. Yeah. I'm usually the optimist, and as I said, sometimes people don't always cope the way they think they're going to. And then people, again, can minimise what they've been through. I should be feeling better by now. I can't understand why I'm crying all the time. It's not like me. Well, it isn't like you, because you've not had this happen before. That brings me a little bit on to communicating with others. We can't read each other's minds. If there's a couple, you've both got the same experience, but you experience it differently and at different times. And it may be that one person one day is feeling actually quite chipper, quite upbeat, and the partner isn't. It doesn't have to be the patient and the family member. And it's not always in tandem. So we just kind of have to accept that that will vary or fluctuate, not just with the patients, but the family members as well. And also, with our stiff upper lip in this country, how are you? So when somebody says to you, how are you? Put your hands up, anyone who just says, I'm fine. Okay. I'm fine. Okay, so on a scale of 0 to 10, if 0 is really, really rubbish day and 10 is top of the world, how are you feeling today? So you could say that. So actually, I'm about a 6 today. Just gives that other person that little bit of indication. You're not so great today, and you're feeling a bit shaky and wobbly today. And you might be a 7 tomorrow, and you might be a 2 the day after. So family members and close friends, they are experiencing all these emotions as well. Very worried, very scared, feeling very vulnerable, confused, stressed, angry. And a lot of what happens in medical interactions is that the patient is always the focus, and the family member sort of kind of has to sit there. And I think people can find that quite difficult. And they can feel a bit helpless and useless. Well, I'm usually the one who looks after things, and I can't help my loved one now. I have to hand over that responsibility to someone else. And sometimes you just don't know what to say. And you're frightened of saying the wrong thing. I feel like every time I open my mouth, I can't seem to say anything right, so I say nothing. And family members often feel that everything is down to you, down to them. So you might be having to do a lot more childcare. You might be having to run around a lot more, do a lot more picking up and dropping and sorting. It's a phase and it will change. But there is this importance of staying involved with your loved ones. And sometimes there is a temptation to distance yourself because this is very painful. And some people will pull apart. It does happen. But it is trying to stay involved as you can and asking what would be helpful. So yeah, what would be really helpful? Well, actually, today, what would be really helpful is if we could just not talk about it today, please. Could we just sort of plan something for next week? Okay. But it's really, really hard, isn't it? I hate seeing her so upset. I keep it to myself. I'm frightened of telling her how I really feel. And often it's like, well, what do you think would happen if you told that person how you're feeling? I'm feeling worried, stressed, and angry. What do you think they'd do? Probably give you a hug, wouldn't they? But everyone will cope in their own way, and there isn't, as I say, a tried and tested rule. And it's very, very natural to protect the ones we love. We don't want to hurt them. You can be overly positive, as I mentioned before. It doesn't always work. Giving advice and finding solutions is not always what's helpful at that time. But also to remember that the person with ocular melanoma themselves can support the people around them. So this is something that comes up an awful lot when I'm thinking about with patients what their main concerns are. Unsurprisingly, one of the biggest concerns is concerns about fear of cancer recurrence. And then around visual loss. But around that the same amount of people, it's actually other people's reactions. It's a rare disease, so this can sort of create feelings of feeling a little bit isolated. It's like your GP might not have heard of it, and people are sort of pulling a face at you because, I don't think we get that. And the treatment itself, well, the radiotherapy takes what, with a plaque, 3 or 4 days? Proton beam, 4 days? That's not 6 weeks of radiotherapy. And that's what people have this sense of when you have radiotherapy. You have a 6-week course. Other people's Googling. And there's nothing you can do about that, really, but particularly if you don't want them to share it with you. And other people's narratives, other people's stories, other people's experiences will inform the way they respond to you. If they say they've got experience of something like this, they might want to chip in and say, well, when I was like this, I felt like this. And there's also unwelcome attention. People can stare and ask intrusive questions, or it might just come out of nowhere when someone bumps into you in a supermarket. And someone could be quite rude and say, watch where you're going. And how do you respond to that? That's really quite hard, isn't it? Especially in the early weeks when you're still grappling with all of this. But ocular melanoma doesn't occur in a vacuum. There's context. There's lives, there's families. Then you may be under financial strain. You might have a lot of caring responsibilities. You may have young children, or you may be embarking on a new relationship. There's various life transitions, coming up to retirement. The median age for this disease is around 64, 65. So we're thinking about, well, actually, I've had my working life. What do I want to do in the future? Your children might be leaving home, which for most of us is a massive wrench. It's a new thing to go through. You may have concurrent physical health conditions. And it might also be a second primary cancer. But you also might be experiencing psychological difficulties now. These might have been long-standing ones that you've had, or it might be concurrent ones. And you may also be experiencing bereavement. So the image of the bucket is that, we carry these buckets around with us and our lives go on and they try to spill out a bit, don't they, at times of strain and stress. And then someone turns the ocular melanoma tap on. And out it comes. People often talk about wanting to get back to normal because they want to be themselves again. They want to sort of, get a sense of who they are. And there's a sense of loss and control over life, and you want to strive to regain and retain some control. And when we do that, we act upon the world, and we have a sense of agency, and we have a sense of purpose, and we feel safer. And often that is tied up with work for people who are at working age. But also it's not just that, it's returning to the family and social roles that you have, and all of that is integral to adjustment. So what I like to say to people is that you're not going to be able to climb that mountain straight away. I don't know if you can see, but she's got a very big mountain there. So it's about small, manageable goals. And people often say, right, well, I've got to start back driving straight away. Okay, fine. Well, why don't you just sit in the car? Just sit in it. Have a look in the mirror, see what you can see. Go out as a passenger, get the sense of movement because it's all different again. And then go round the block. Don't go down the M6. So, forgive me for this model. So this is, James Brennan is a clinical psychologist working in Bristol, and he's done a lot of work in psycho-oncology, and he talks about this model of adjustment. If I can get me pointy to work. So we have this mental map of the world. It's who we are, our relationship with the physical world, our social world, our work, our future, our families. This is kind of who we are. And we have expectations about what's going to happen in our lives. And for example, you've got an 18-year-old child who wants to go to university. So your 18-year-old child gets the A-levels, gets the offer, gets the place, and you can confirm, and she goes off to university, or he does. And that strengthens this mental map, makes it more solid again. Yes, okay, we've got this new information, it's good, it's what we expected. It's when things don't go as expected, and our experience contradicts what we wanted. And this, again, the depth charge, giving rise to stress, giving rise to those natural defense mechanisms I talked about. We have to filter all this new information. We have to mobilize our coping strategies and find new ways. These are psychologically shocking events, and they challenge that assumptive world that we have. Our life narrative is altered, but over time, and it's a process, this is not a single event, the new mental map emerges, and these experiences are weaved into the assumptive world, and some people talk about this as the new normal. But often what can come out of this is that sometimes there is benefit from adversity, and there's something that's called post-traumatic growth. And there are positive life changes that can develop through a stressful and frightening time. You might feel a deeper connection with people. You might appreciate things differently. You change your priorities. What's really important? How do I want to live my life now? But you can also gain a sense of personal strength. Look what you're going through. Look what you've done, how well you've done. And I think that's it. So just to summarize this part of the talk, you've experienced a psychologically shocking event, and it does have significant effects on yourself and others. And it will give rise to some very, very powerful emotions and thoughts. We try and draw on our existing ways of coping, but we might need to develop new ways of coping. It challenges the assumptions we have about our lives. And adjustment is a process, and it takes time. And this is something called post-traumatic growth. Oops. And that's the cue for a break.